Hi, welcome to the April 22nd Addiction Toxicology Case Conference. This is brought to you from the American College of Medical Toxicology and American Society of Addiction Medicine as joint webinar partners. Please visit our FAQ page for prior Addiction Toxicology Case Conference webinar series facts, as well as previously recorded sessions. There's several years of recordings from monthly sessions on a variety of addiction toxicology topics. I'm Tim Wiegand, Director of Addiction Toxicology and Associate Professor of Emergency Medicine at the University of Rochester in Rochester, New York. And my co-moderator is Dr. Gloria Bashevitz, Medical Director of Strong Recovery and Professor of Clinical Psychiatry and Department of Psychiatry, also at the University of Rochester. None of our speakers have any conflicts of interest. Other panelists are Dr. Chris Davis, Assistant Professor, Medical College of Wisconsin, Milwaukee, Wisconsin, Dr. Phil Moore, Medical Director for Central and Western Regions, Videnzia Incorporated, Harrisburg, Pennsylvania, and Robert Cole Puringer. Dr. Puringer is a hospitalist and medical toxicologist and addiction medicine fellow, Hennepin Healthcare, Minnesota Poison Control System, and the University of Minnesota, Minneapolis, Minnesota. And Dr. Ross Sullivan, Assistant Professor of Emergency Medicine, the Toxicology Fellowship Director at the Upstate University Hospital, and Medical Director of Helio Health, Syracuse, New York. And none of our panelists have any conflicts of interest. All right, perfect. Okay, so stimulants, stimulant use disorder, level of care, confidentiality, and clinical conundrums. Thank you. All right, so the first case involves stimulant use disorder and detoxification. We have a 31-year-old male who has a history of opioid and stimulant use disorder, and he presents to an area detoxification clinic with medically managed and medically supervised level of care after 3 days of heavy methamphetamine use. He reports methamphetamine, some fentanyl, and cannabis for the past 3 days. He smoked and injected methamphetamine. He's injected 3 times with fentanyl in the last 24 hours. He is prescribed buprenorphine, and the last buprenorphine was 3 days prior. As part of the intake, the urine screen is done, and it is positive for methamphetamine, amphetamine, cocaine, THC, fentanyl, and buprenorphine. And this is just a presumptive or preliminary screen. He is known to the facility for prior admissions for opioid use disorder with concomitant stimulant use. In the past, usually cocaine, both smoked and injected, and was last in detox 4 months ago, linked to an inpatient and then to an intensive outpatient. He has no primary care provider. He lives with his significant other and her kids. He can stay there if he's not actively using, but he has not been home for a few days since his relapse. My question for the panelists, we have a couple, is what type of information is needed for intake and admission for this patient beyond what we have? And then what types of comorbidities and or complications are seen with methamphetamine use? And then what information is important in making a level of care assessment for this patient? And then for the audience, if you have comments and questions, go ahead and put them in the Q&A and we'll answer them as they come up. So Dr. Moore, can you, start us off? What information in addition to what I provided do you want?
Well, so what glaringly comes to mind with someone that's had extensive treatment history is why haven't things worked in the past? What have been the barriers? What has happened? What's stopped treatment? And I would also like to know about how they've been taking their buprenorphine. Are they just intermittently using, or, which it seems like with this presentation, they're probably just using once or twice a week, but I would want to know more information about that. And then more things about his physical state and hallucinations, paranoia, sleeping habits, that kind of thing, to make a safe determination for medications and that the level's appropriate level of care.
All right, Dr. Davis, what about you?
I'd share the same concerns. You wonder when these people come into detox, what's happened and why after that history have we failed? And I would be very concerned about psychological comorbidities and whether or not this is a safe presentation. And sometimes it occurs to me that out of advocacy for both the patient and the staff, we have to consider sending to a tertiary care center. If there's a history of acting in a way that's a danger to himself or others, that's a strong consideration. And sometimes that's the better part of valor.
Yeah, certainly some of this could potentially depend on who's at the facility, time of night, is there history of violence? I'd want to know if there was any awareness or footage of what they were doing in the parking lot ahead of time. Is this somebody who's got a lot of psychomotor agitation? And then what medications are available on site for de-escalating if need be, and the staff, how are they interacting with the patient during the intake? Are they able to calmly de-escalate if there's any agitation? Dr. Sullivan, what are your thoughts?
Yes, what everyone said, I totally agree. And one thing that I also really am interested in are the real severe medical comorbidities that we are seeing with people use methamphetamine use. And, several years ago, most of, say, endocarditis patients were intravenous heroin users, but the number of people, that I'm seeing in the hospital with endocarditis and valvulopathies and all these other problems that we thought were more just opioid intravenous related I'm seeing now in people just use amphetamine. So, number one is obviously if they're ill with one of those things, we want them to go to a tertiary site. But, when you're looking at for what a level of care is, often historically, these people were put more in an inpatient, maybe not a need for like detox, so to speak, like we do with opioids. But the level of thinking has changed a little bit recently. And I think that, the comorbidities associated with amphetamine use have really increased to things with like the cardiac problems. And so dangerous use, intravenous use, the living situation, their medical history as a result of amphetamine use, all these things I think need to be taken into account, and whether or not this person goes to detox, whether they need to go to the hospital or something a little bit more long-term.
Yeah, those are great comments. As a patient has IV drug use, certainly, do they have abscess, infection, are they febrile? A lot of the comorbidities with the more severe protracted methamphetamine use, toxic psychosis, trauma, high-risk behaviors resulting in trauma, as well as infection sexually and injection drug use related, dental caries and teeth abscess, a lot of comorbidities. Dr. Perner, do you have any thoughts?
I don't have a lot to add to what people have already said. I guess of utmost importance, I think, is just like one of the prior panelists mentioned, how consistently they are taking the combination buprenorphine naloxone products. Like, what do we have to be concerned for? What other substances are they using? What withdrawal syndromes or intoxication syndromes are we need to be concerned that are overlapping? And then maybe some other things. I mean, you had kind of mentioned it, Tim, like what is video footage in a show of them? Is there any trauma that we need to be worried about? Head trauma? Was there any recent self-harm that we need to be concerned about? What's their housing situation like?
Yeah, great comments. And Dr. Bishevitz, do you have anything to add, or is there anything in the Q&A?
Whoops, got to unmute myself. Nothing in the Q&A so far, and I think we've already mentioned most everything, including all the possible psychiatric complications. And, certainly sometimes these folks get admitted to ED overnight beds or even to psychiatric units if their paranoia or suicidal thoughts are severe enough.
Yeah, that certainly can occur. And then it brings up the whole challenge of the handoff and collecting information. The detox level of care is particularly vulnerable, getting patients from a variety of settings, sometimes from across the state, sometimes from area psychiatric facilities with walk-ins, and trying to assess Patient background risk can be very difficult depending on resources and access to electronic records, as well as even information coming from the hospital. So,
Well, and one thing I always find helpful is thinking about discharge on the day of admission, thinking about what to aim for in the future. Should it be inpatient rehab, or should it be a prolonged community residence type program? What are you going to try and get the patient to do?
Yeah, I think that's a great point. One of the things that we would get for this patient is look up the prescription drug monitoring program, see how frequently they've been on buprenorphine, and so this individual had gone on a stimulant binge and stopped taking the buprenorphine. So maybe even some consideration right at the front end of the monthly injectable, and in addition to the methamphetamine, calming the impending crash, there's also the question of what do we do with the buprenorphine and how do we restart it? Are we at risk for precipitated withdrawal? If the patient has truly been taking it for 3 days, that urine buprenorphine gives us little information, tells us it's there, but it doesn't really tell us how much. The same thing with the fentanyl. Okay, so there's some more information. The patient reports he has not slept in 3 days and he's starting to feel opioid withdrawal and concerned about restarting buprenorphine because he's been off of it for a few days. His vital signs, his heart rate's in the 90s. His blood pressure is 140/94. He's breathing at about 20 per minute. He's disheveled. He's pacing. He's irritable. And despite it being tangential and psychomotor agitation, he's got some frequent repetitive movements. He is not hallucinating. He's able to provide a fairly coherent history. His skin shows stigmata of IV drug use, but there is not any cellulitis or any obvious cellulitis, nor abscesses. He is not overtly diaphoretic. There's no piloerection. He's oily and disheveled. He's been injecting in his arms as well as the left neck, but again, no signs of abscess. His meds, he is prescribed meds, but he says they're gone, other than he has 18.5 of 8/2 milligram buprenorphine films he brought in from a prescription for 28 days that is about 10 days old. He had a hospitalization about a month ago for paranoia and suicidal ideation after use of cocaine. There was protracted smoking. He had chest pain, was in the ED, and after coming into the ED with chest pain, he was noted to be paranoid, tachycardic, and expressed suicidality, but he had no prior self-harms, didn't have a specific plan, was cleared from the psychiatric unit, and apparently went back just to his outpatient and home. He denies any alcohol use, denies benzodiazepine use. He has tried synthetic cannabinoids in the past, but stopped after a few episodes resulted in repeat hospitalization due to psychotic behavior, but that was several years prior. He smokes 1.5 to 2 packs a day. During the intake, an attempt to reevaluate or evaluate, he is leaving the waiting room several times to go outside and smoke and walk around. So the intake is interrupted by his restlessness and irritability. So it's evening. Nursing coverage is 2 LPNs for 28 patients and 2 client assistants or CAs. The physician is off-site. There's 24 hours to do a history and physical for the detox, and then remote coverage. Nursing are anxious about patients' behavior, but asking about appropriateness for admission. There's no on-site security. So question, what are your thoughts? And if admission, what are your orders? And in an ideal world, what considerations do you give this patient? How do you approach or de-escalate any agitation or behavior? So some of the same questions. Now we have more information. Dr. Davis, what do you do?
Reassure the nurses and reinforce the notion that they should behave in a calming manner, and we can go with our usual medicines and help, hopefully, to stabilize the patient with benzodiazepines and olanzapine. I'm also concerned that the patient was allowed to go outside and smoke, and that's been a traditional opportunity to use again. And if they already had their UDS, then they might be using something that we're missing. So I'd ask them to look for that too. But most of all, I'm concerned about signs of paranoid, delusional, and escalating behavior. So I don't want to get the medicine on board soon. And if it starts to escalate beyond that, then we'd have to make a decision. So I'd encourage them to call me frequently and to keep in touch and to triage appropriately.
Yeah, good points. And hopefully the individual doing the intake is able to focus on the patient and calmly and with hopefully a connection with the patient, maybe sitting down, just trying to keep them in the continuous evaluation. So this not this in out, because I would want to know, okay, if they're leaving and the patient comes back and now they're all sweaty and tremulous and heart rate's way up, did they just use another methamphetamine again? And we're at more risk for acute sympathomimetic toxicity, which needs to be treated in the hospital potentially. But they just take a bunch of sedatives to come down. So we really need to be cogent for a evolving toxidrome. Dr. Sullivan, do you have thoughts?
Agree wholeheartedly with Dr. Davis. I mean, the first thing you're really supposed to do, right, is ensure the safety of the patient, but also the staff, right, and the area. So, it's important, if we have more experience with these patients and say the nursing staff or these LPNs. But obviously, we gotta be mindful of the fact that maybe this is someone that needs to be brought to the emergency department, with if there's escalating, agitation or escalating, abnormal behaviors or aggression, these people should be promptly brought to emergency department. But before that, to de-escalate the people, I mean, there's people who are on this call are experts in de-escalation, or de-escalating, I should say. I wouldn't say I'm an expert, but we know that you first ensure safety, you help the patient manage their, their emotions and behaviors. You want to avoid, physical restraints, obviously, which, and then, avoid coercive interventions in language, and try to develop some type of, relationship quickly with that patient. And I think, in doing those things, if you can't achieve that, then, it is okay sometimes, to send the patient to the emergency. And I'm an emergency physician, so, to say that, but, it is okay sometimes. And when the safety of the others are in question, if this person escalates even a little bit more and wandering around and having some more agitation, if your medications don't work, they might need to go to the emergency department.
Yeah, and there's certainly a way to do that, I think. And it wouldn't be right up front, say, you seem to be really agitated. If anything goes wrong, we're going to send you to ED or call police. And so calming demeanor and just kind of some observation as well, I think really sets the stage. And this gentleman hasn't eaten for 3 days, so I would offer some fluids and suggest, say, are you hungry, which also tells me no, I'm nauseous, but vomiting, or oh yeah, I am hungry. Well, we can get you a snack in just a little bit. So there's some gestures that show we're concerned and not just doing the intake and you get in, but really giving him consideration about health and that he's been up for 3 days and hasn't eaten, and some other things. So Dr. Moore, do you have other comments?
Yes, I have a couple. So what comes to mind, and what I often have to remind staff, nursing, other physicians, is that this patient came to us for help. They're an active audience. They're there, they want our help, and we want to find a way to help them and not create barriers and restrictions to send them out, elsewhere. It is appropriate to make referrals, but they might not need to happen for 2 weeks, 4 weeks, months. So I frequently remind everyone, take a temperature pulse and remind staffing of that. And on that point, if he's there voluntarily, he's not being ordered by parole, probation to be there. He's there voluntarily. So if he's getting agitated, there's something going on. Are we causing it? Is this a iatrogenic agitation from over medicating with like a benzo or too much anticholinergics? What's going on? Because he's here voluntarily. So if he's agitated, he could just, he could just leave. And the other thing is I frequently make sure and do checks that everyone's getting appropriate education about de-escalation. Role playing some of these scenarios works really well in between some of these people coming in. So I mean, I think he's in the right place, and we can provide at this level of care for him. As far as medications, even though he's not overtly sympathomimetic, I frequently recommend everyone in our organization, at least, to use drugs like clonidine, lofexidine, because they will help calm. And the toxicity from the drugs is they sleep, and that's really what we want here. So while the antipsychotics might be added too, just to kind of help that, really pushing the sympathomimetic class of medications can be especially helpful for these individuals, because they just need to get caught up on sleep frequently.
Yeah, you mean the sympatholytic, right?
Yeah,
The
right.
alpha
Correct.
2 agonists. Yeah, for sympath. Yeah, I like that idea. I think certainly his blood pressure was not low. He's probably dehydrated, but clonidine, lofexidine, the little more expensive, I think. So some of the consideration around coverage and cost, but I do like clonidine. Dr. Perninger, you have thoughts?
I guess based upon what initially heard of him, I'm actually I have a very low threshold to transfer him to the emergency department or additional levels of care. I guess given what the history and what we've said, we haven't even restarted buprenorphine yet. He is showing signs. One, he has a repeated history of either a primary psychotic disorder or a substance-induced psychosis, probably going to require some antipsychotics, probably going to require some benzos. And depending on what your nursing coverage is at the detox, 2 LPNs here overnight sounds like a pretty good thing. But I'd be worried that they're becoming sympathomimetic and could be quite quickly, and that they will need higher doses of benzos and antipsychotics, and then that they won't be able to handle them. So I think a very low threshold to escalate or transfer this person to the emergency department.
Yeah, I think you bring up good concerns. Certainly, which trajectory this individual is going. Is he ready to kind of essentially go to sleep if the appropriate medications and course occurs, or is it that he just used and he's kind of evolving, or gets stuck in paranoid agitation because of a variety of factors. So yeah, this is a tricky patient, which is one of the reasons why we're discussing the stimulants. Is they're much more common, and parts of the country methamphetamine has been around for quite a long time, but in upstate New York, in the city of Rochester, it is infrequently seen, usually when somebody's been transferred in, but it's really starting to be more prevalent as it's made its way in from other parts of the state and just becoming more prolific. And I think the population of patients with opioid use disorder in general are also now using more methamphetamine concomitantly, as well as it's just more ubiquitous. Dr. Bashevitz, do you have any comments? And
Yeah. Yeah, well, there's actually a good observation in the chat that Ingrid Vinkus gave me this idea because she is calling this patient too unpredictable, and she's saying that that's why she would maybe want to transfer him, that this patient might be too unpredictable for this level of care. I think that's a very important thing to think about when you're monitoring the trajectory of a patient like this. You need to go back and assess him more than once to see which way that trajectory is going. Very important. Another interesting question that came in is is one that says, I work in a safe injection site and see many clients that share very common but unusual body behaviors, including not being able to stand up straight and several clients being hit by cars and buses. I guess I can understand the cars and buses thing if people are actively using, but have you ever heard of not being able to stand up straight when using some of these medications?
That's interesting. I guess I want to clarify that. If somebody's got back pain with injection drug use, that brings in a whole host of diagnoses. Are they febrile? Do they have an epidural abscess, a paraspinal abscess, osteomyelitis? Is there trauma by a car? I mean, methamphetamine, intoxication. People can become quite agitated, and in parts of the more severe intoxication, and somewhat impervious to pain to some extent. So is there an injury? There are movement disorders that one sees as with dopamine depletion and with some of the other psychoactive chemicals. So I want to know, is this just somebody stooped over? Do they have a fever? What does their back look like? What do their legs look like? Do they have myoclonic jerks or twitches? Are they tremulous? Are they stiff? There's a whole host of things that could be occurring if someone is stuck in one position. Neuroleptic malignant syndrome. Are they did they get a bunch of antipsychotics and promethazine, and they're stiff because of that, and they're also febrile. So that's where the good clinical exam, vital signs, and history are important. So some great questions and comments. Any other additional questions or comments at this point?
No.
Okay, let's keep moving on. So the patient is admitted with a lot of caveats, and the caveats are really monitoring for any escalation in symptoms and warning signs, and a stat order of olanzapine. There's a e-kit at the detox, which contains a variety of different medications, including olanzapine 2.5 milligrams, so 2 doses of that, with a repeat in 2 hours if symptoms not improved, and to notify a provider if any escalating symptoms are concerned. Diazepam is also ordered with olanzapine and to repeat 3 times as needed from the e-kit, and adjunctive clonidine 0.1 3 times. And there are some other medications, including hydroxyzine, melatonin, and other standard supportive meds, but I wouldn't be giving those right up front. I would be using the olanzapine, diazepam, and clonidine. I think it's a great idea, as Dr. Moore suggested. Any other comments regarding this, Dr. Sullivan?
No, this, I think that pretty much covers it. This is in a detox that's not really a hospital monitored level of care. There's not a ton more you can do other than variations of the theme here. Benzodiazepines, antipsychotics, some adjunct medications, patient-centered care. And I think this is it for now.
Yeah, in New York, there is a lot more encouragement from the state's agencies for this level of care to take patients that are, even if there was no opioid use, coming down from methamphetamine or synthetic cannabinoids, and being able to deftly manage that first 24 to 48 hours. And even those first couple of hours where really you identify which trajectory this patient is going is so critical, because if this is at night, there's no providers and physicians that are advanced providers on site. You're left with you need to really rely on the nursing and and support staff to give reliable information and to document appropriately as well. So Dr. Moore made a comment of role playing, and I really like that. I think that's really important. Dr. Pernger, any thoughts at this point?
I don't have a lot to add. I agree with everything Dr. Sullivan just mentioned.
Okay, let's move ahead. So beside the neuroleptic and benzodiazepines, are there other options for this subacute intoxication? I mean, assuming this isn't progressing into sympathomimetic toxicity, where he's just used in the parking lot and becoming more restless, his heart rate's going up, blood pressure going up. Assuming this is used hours before, and this is kind of, or even longer, and it just hasn't been able to sleep. Had you also used an opioid? Now he's in the transition kind of phase, paranoia, restless, can't quite sleep, needs to sleep. Any other medications or treatments for that? Or what about toxic psychosis? If you're in the emergency psychiatric units, this patient maybe had more paranoia, some hallucinations, not appropriate for the medically managed, medically supervised level of care. What do you use in emergency departments? And then just comment on specific drugs, route of administration, dosing. We'll start with Dr. Bishevitz. What do you have options in the clinic if someone comes into strong recovery and they're showing signs, maybe not needing emergency department transport? Are you able to give medications from the clinic, from the opiate treatment program, or?
Well, no, unless they're in our stabilization program, and then they can get things like sublingual buprenorphine or something like that. But they'd have to be in that particular level of care. We don't usually give clonidine unless, though sometimes we give it as an adjunct for stabilization.
Yeah, so it's the patient going into opioid withdrawal, and that's the primary issue driving some of the restlessness. Certainly, that we should be able to differentiate that. Dr. Perner, comment, even if not the detox setting, what about emergency department? Or
so I'm not an emergency physician, internal medicine, so I don't see a lot of this in the emergency department. But other than that's been what's mentioned about opioids and potentially restarting of buprenorphine, things like that. That's kind of the next step I'd go in addition to what you already mentioned with the neuroleptics and benzodiazepines. Higher doses of the neuroleptics, particularly given that I'm very concerned that this is unmasking of an underlying primary psychotic disorder.
do you have a particular neuroleptic that you would start with?
I usually start with olanzapine, and it's mostly just because that's what I have experience with, and that's what I've given in the past. I usually will do 5 milligrams PO followed by 10 milligrams PO, and if that's usually what I'll start with, the disintegrating tablets.
Oh, good. Okay, Dr. Sullivan, what about your?
Yeah, I think in the emergency department, I sometimes if they've gotten olanzapine at the detox, I might use olanzapine again. I've been using droperidol actually quite a bit lately. Some recent emergency medicine studies suggest that we know that it has a safe profile, and it was blacklisted versus haloperidol, which we found out was kind of erroneously done. I like it. It's IV, it's IM, very safe profile. Recent studies show that if you give droperidol, the use of needing other medications might be less compared to something like olanzapine or even other benzodiazepines. So if they make it to the emergency department, if they're willing to take some more olanzapine, they're just a little agitated, that's okay. Just the other day, I had someone who couldn't stay in their room. They're mild, little aggressive, starting to get a little bit worse. And we gave them, I think it was 5 milligrams total of droperidol, and did really well, and was able to go back to the detox once the acute or subacute intoxication improved. So I use those things and have been using droperidol much more lately.
Yeah, that's great. That goes back to medical school and residency, where I saw a lot of droperidol used initially, rotation Denver General. It seemed to be extreme, safe for controlling agitation when medication was needed, while there was other intoxicants on board, including alcohol and stimulants. And so I had a lot of experience at that there, and then residency in Hennepin County Medical Center. And then it had the black box warning for QT prolongation. So really, use fell off incredibly, but it's the reanalysis of the risk profile. We've seen more use of the droperidol, and I agree, AED in the hospital setting in particular, that isn't available at this detox level care, but for acute agitation works pretty well. Dr. Moore, do you have any other thoughts? You commented on the sympatholytics, clonidine, lofexidine.
Several. So one, we use dispensing cabinets, so we can access medications very quickly, and that's something that I think others could consider integrating as well. So you have a remote pharmacist that verifies the order and unlocks the drawer, kind of like a hospital Pyxis machine. That works very well in the detox settings. Regarding specific medications, I'm comfortable using whatever antipsychotics are available. But if there's certain ones that I'm a little more cautious about, because if we're treating for agitation and the drug can paradoxically cause agitation, it just makes me a little uncomfortable. So if I'm going to use those antipsychotics that are associated with those anticholinergic type effects, I try and keep the doses lower. So my go-to antipsychotics in this scenario are going to be more of the risperidones and ziprasidons, and just because those would be available in a cabinet and would be able to be administered, oral, but I wouldn't have any issues with droperidol or haloperidol or any of those either if they were available.
Good comments. I appreciate in detox setting, there's often order sets that include hydroxyzine, diphenhydramine. Patients may also come in with prescriptions for quetiapine, and so you may have 3 or 4 different medications that are antimuscarinic, anticholinergic, and certainly need to be wary of complicating any delirium with that. That wasn't the case in this patient, but so I think that watching the dose certainly, and reassessment of effect is good. Dr. Bishevitz, do you have any thoughts? Any other comments?
Mainly that using the antipsychotics is quite an art sometimes, and one of the things to be aware of is if the person is an existing methadone maintenance patient, they can have a higher risk for QT prolongation when other QT prolongers are added to the methadone. So that's a good thing to bear in mind. And in terms of what's in the Q&A, there's one comment that says that we should remember that many substance use counselors are very effective at talking people down without need for medications or law enforcement involvement. And I think that's a very good point. Many people can be talked down. There's another question about, do you have any experience with cariprazine in these patients?
So I really appreciate the strategy of talking first and using the least restrictive or invasive technique, and that begins with just kind of calming demeanor and general approach to talk, and that takes some skill and modeling, and so it's certainly a learned behavior, and then there's a progression of steps that one would take. I don't have experience with cariprazine in this setting. I'm trying to recall what I believe that's a newer medication. Is that a partial dopamine agonist?
Yeah, I believe so. But if I could mention the trade name briefly, the people will recognize it as Vraylar.
Yes, that's what I was thinking of as well. But it is very new, and I think they're probably pretty expensive. And I thought the indications were just for a certain subset of bipolar affective disorder. But the addiction psychiatrists have more experience with that. The psychiatrists, I don't have any experience in use and treatment of agitation from medications or in this setting or BD hospital setting.
Yeah, it would certainly be something that would be lower down on the list of medications to use because, for one thing, it's prior authorization and very expensive. So it's something that I don't have much experience with either for those reasons. But the questioner mentions that there are 2 studies of cariprazine with amphetamine and cocaine.
That's great, though. Take a look at that.
Yeah.
There's a new product that just came out, sublingual dexmedetomidine, which is shorter acting sympatholytic, more selective for the alpha-2 receptor, so you have less side effects compared to clonidine, and even potentially lofexidine in sublingual form. Pretty rapid onset that just became available for control of agitation with certain types of mood disorder, but maybe a very useful medication. If there's no IV access or just sublingual to de-escalate agitation, but certainly more to be seen with that. Dr. Davis, any final thoughts on this point?
No, other than we were talking about using these medicines, and I think we have to be careful and recognize that very often we're treating the milieu, the other patients and the staff. And upon review, if there is an adverse outcome of any sort, sometimes the review, and including the video, will exhibit that agitation refers to the staff as much as the patient, if not more. And sometimes I think it's prudent to refer to this phenomenon in the patient as psychomotor acceleration, and to be as neutral as possible, because just using the term agitation can be, I think, it'll really seed that in the staff's mind that this person is agitated and they're beyond hope. They need more medicine and they need to be sent to the emergency room right away. And so I like the notion of approaching these patients in a gradient fashion. And sometimes we don't have the time and we have to jump to the heavier drugs. But I think in the context of supporting the staff and watching out for a toxic mix at late at night in a detox setting is something that is part of the triage undertaking, and frequent touching base with the staff and monitoring the patient and reassessing what we're doing is indicated, and hopefully it'll be more successful that way.
Yeah, no, that's a good comment. I think in the words that one uses in communicating with the nurse, instead of watch for progressive agitation, you need explaining the signs or symptoms, so you don't, depending on experience, you don't kind of prime someone for a expectation that may not necessarily occur. So good comments. But what about the opioid use disorder? So you've got to determine when to restart this patient's buprenorphine, and we're in the era of fentanyl. I'm assuming that's, he said he's using fentanyl. We don't have opiates showing up on the screen. So, how reliable is his history? Does have buprenorphine in? So how would you restart this patient's buprenorphine? When? What would you do for monitoring withdrawal? And it's just certainly going to be overlap in some of his symptoms and scoring on the COWS, clinical opioid withdrawal scale. So I'll start with Dr. Sullivan. What are your thoughts?
Well, hopefully, he gives us some information by talking to us, depending on how agitated he was. I think in the beginning there was some mention maybe of fentanyl or something that might have been either in his meth or something. We're not really too sure, but he said he was off his bupe for a couple of days. Maybe he was concomitantly still using meth with fentanyl in it, but I think that if there are maybe some signs of opioid withdrawal, I would start him at a low dose. Some places can microdose, some places cannot. But maybe if it's 2 milligrams, if there's some signs, and it's hard to say, like Dr. Davis said, there's also so many other drugs and things are in people, who knows where he is on a COWS spectrum versus acute intoxication of amphetamine and another spectrum. But, if the patient's even saying, I really need something, I feel like I'm in opioid withdrawal, or if there's some nausea or some vomiting, I think it's appropriate to start at a low dose, 2 milligrams, even if you can cut it in 1 milligram, if your place allows you. I know in New York State, we have a problem with cutting any tablet or film, which unfortunately doesn't allow us sometimes to go lower than 2 milligrams. But I think it would be worth maybe in this patient, if there was some hard sign or some other information, to start him on a low dose. And if we precipitate some withdrawal, we can macro dose and get them out of that fairly quickly.
Yeah. So just to refresh, this gentleman had said 3 days prior was using the buprenorphine. He's prescribed 8/2 3 times a day, and stopped. He's missing most of his prescription, but did bring in some, and he does have buprenorphine in his system. So, this is easier if it's in the hospital ED setting. I would start with a low dose of 300 micrograms right away, see if he tolerated it. We have a rapid microinduction protocol that could go up from 300 to 1 to 2 to get him back on quickly. If he truly is at 3 days, he probably could be restarted if he was taking the buprenorphine consistently, you would still have enough in to pretty easily start. This is the area where it gets difficult if you go into 4 days and it's not restarted. Now he's starting to go into more withdrawal. How much fentanyl does he truly have in him, or is this just buprenorphine withdrawal? So I appreciate the start low and go up, and some of the limitations really occur by the setting. Dr. Moore, do you have thoughts?
Yeah, sure. I wouldn't make this a really complicated matter. I would just simply ask him. He's obviously knows how to start and stop his buprenorphine. So I would ask him how he would prefer it be restarted and when. And that will also help manage any agitation, because oftentimes they're very opinionated about how their medication should be administered. So if we just address that right up front, let him control that. Usually that's another de-escalation technique that can be very effective.
Yeah, that's a good comment. Now, he's expressed some concern about precipitated withdrawal because he's been off for 3 days. And in my area, I see patients that if they've had precipitated withdrawal once, they're very hesitant, even if they've only been off of buprenorphine for 1 or 2 days. Don't really appreciate the risk. If somebody is experienced and says, no, this is what I anticipate would happen, I would be more inclined to follow their suggestions. But I'm looking to see for some mild withdrawal, start low and go up. Dr. Bishevitz, your thoughts and anything in the chat?
Nothing in the chat, but my main thought about this is all things being equal, it's great to get the person back on the buprenorphine as soon as possible, because there's often a calming effect to that, even if the opioid withdrawal symptoms are mild. And again, like Dr. Moore is saying, you can let the patient drive that situation too. And if they want to start back on their buprenorphine, they're going to feel like they were heard, and at least there's something that's going to be helping them out.
Yeah, that's great. Dr. Perner, any thoughts?
I don't have a lot to add. I really agree with everything that Dr. Moore, Dr. Wiegand, and Gloria had mentioned. The one, I guess, if the history is true, I'm not that concerned for precipitated withdrawal. I think the first 2 milligram dose will tell us quite a bit as to how fast we need to go, and whether we could just restart them fairly quickly on close to what his PTA dose was. And I think it also is adamant to get this started as soon as possible. 1, for comfort, and 2, just to get another variable out of the equation so that we can see how we can better manage the rest of his symptoms.
Yeah. I think if the patient was going to sleep right after the olanzapine and diazepam and just kind of slept through the night, I'd probably aim for the morning. If he was up still, or any of the symptoms, aches and some mild withdrawal, I'd go ahead and go with the 2 right away then, and then another 2 an hour later. But we'll keep moving on. The second case is a bit shorter though. The patient is admitted and placed on Q30-minute checks, initially just post monitoring. He's given the 5 milligrams olanzapine and 5 milligram diazepam, and able to sit and talk to one of the client assistants who has a calm demeanor. Fortunately, a single room was open, so the patient's without roommate. Despite it being past dinner, he's offered some food and snacks, some amenities, water bottle, the material, an option to have staff clean clothes and wash while using some stock garb. So patients is ordered buprenorphine naloxone 2/0.5 to start. 12 hours to last opioid use, or if the count's over 10, and then times 1. So he could start in the middle of the night. He did not want to start right when he entered. And that's the lowest dose available at the detox facility. And after the second two, it's restarting to 8 and going up to twice a day. He concedes that he was not taking the 3 times a day, usually 1 or 2 of them a day, and he would subsidize his cocaine or methamphetamine binges, usually within a few days of prescription, but he still kept some so he wouldn't go completely without. So here's an opportunity to maybe talk to about subcutaneous buprenorphine as an option. So just a couple questions. What treatment options are there for stimulant use disorder? Comment on specific treatment for cocaine versus methamphetamine. Does anybody have thoughts? Dr. Bashevitz?
Well, certainly for cocaine, you think of off-label use of topiramate or maybe disulfiram. I get a lot of takers for topiramate, but very few people in my experience wish to try disulfiram. Though sometimes I offer it to people who also have alcohol use disorder. And as far as methamphetamine goes, there's that paper I think you mentioned about the use of the naltrexone plus bupropion for that, and of course contingency management with all the stimulants.
Yeah, great. I think you covered pretty much my experience. There's historically baclofen, but the evidence I think with baclofen for cocaine has really not been borne out. And I see patients either just not taking it or sometimes, using it as a sedative. The topiramate is usually my go-to for cocaine. I don't see that it works well for methamphetamine. Dr. Moore, you've got to move here in other case. Any other thoughts on cocaine or methamphetamine?
Yes, if the individual is really struggling with stimulant withdrawal, that can be really protracted. Sometimes if it's just a big barrier and causes their recurrent relapses, I will offer them drugs like Provigil or modafinil, armodafinil, those drug classes. I make it clear that insurance most likely won't cover, but it's much cheaper than a stimulant use disorder, and you can usually assess how motivated they are for treatment. So those work really well, and they help keep the patient out of the lows of the withdrawal, so they get a lot better energy. The other classes that I use, naltrexone I've used. It also depends what other overlapping meds they're on. That can be a barrier often for naltrexone, but the topiramate and zonisamide are also very effective for the stimulant use disorders. They work really well for a lot of drug cravings and stimulant use disorders when they become refractory.
Okay, very good. Yeah, just in the interest of time, this is just a small study looking at topiramate and cocaine craving that had compared to placebo. The y-axis is percent of days where there's non-use, and this is 12 weeks. Started at week 1, where the topiramate was titrated up from 25 twice a day up to 100 milligrams twice a day. And you see at the end of 12 weeks, there's a significant difference in overall non-use days. There's also other markers of improvement. There's a number of individuals that made it 12 weeks with no cocaine use. And so topiramate, usually I leave it at 50 milligrams twice a day. The disulfiram is interesting. It's a different mechanism than its effect on alcohol. It's an inhibitor of dopamine beta hydroxylase. And the way I understand is that it's less jump in dopamine when you have cue-induced craving and craving of cocaine. So it's not making individuals sick, but there is some benefit from disulfiram. Of course, people need to avoid alcohol. And then for methamphetamine use, there's recently a study in the New England Journal of Medicine looking at naltrexone and bupropion at fairly high doses. And then, as per Dr. Moore's point, the use of stimulants is being studied, and will be interesting, to look at the generalizability in the studies when people are prescribed stimulants for stimulant use disorder. I think your point in the detox setting and post acute crash is a little bit different than for the overall stimulant use disorder. So the patient is continued on olanzapine for 2 days, doses, and does well. He was prescribed quetiapine at home, did not bring that in. That is reordered, and then plan his inpatient referral program that can offer subcutaneous buprenorphine. And we're going to just jump to case 2. This is a case that involves consent It starts with the amphetamine prescription and won't let me talk to his doctor. So 22-year-old male with polydrug dependence, including severe stimulant use disorder, has recurrent binges using either methamphetamine or cocaine shortly after receiving his monthly prescription for amphetamine. An outpatient treatment provider is contacted by the mother, who is irate about her son's prescription. She reports a psychiatrist is prescribing amphetamine. Every time he fills a prescription, he gets mean, and then it's the same thing again. She describes binge use and progression to cocaine or methamphetamine and a variety of complications: legal, hospital visits, mental health arrest or transport, and driving impairment charge. He's calling the clinic because the psychiatrist won't return her calls, and his son has rescinded consent. This has been going on for several months. Patient is new to the clinic, referred by a drug court after a brief incarceration. Has been on and off medication for opioid use disorder, buprenorphine. Patient's prescription drug monitoring program that the iStop shows 20 milligrams of amphetamine IR 4 times a day, usually filled every 28 days. There's additional clonazepam, zolpidem, and those are prescribed by the same psychiatrist. The other medications that he takes are the buprenorphine, naloxone, gabapentin, and quetiapine and promethazine. There's also medical cannabis prescribed but not filled by dispensary. He has only had intake appointments, an appointment via telemedicine scheduled for the following day. No consent for mother or providers on file. I'm just going to go through this and we can kind of have some brief comments at the end in the interest of time. The prescription monitoring program confirms what the patient had reported. There's also some prior temazepam and alprazolam prescriptions, but those are not current. So some comments. Can you respond to the caller? What are your limitations to CFR 42? And then how do you approach this patient on the initial call? The only information is the limited intake about opioid use disorder, cannabis use, the referral information from drug court, and then his past medical history, ADD, ADHD. That's why he's continued on amphetamines. He's got depression, anxiety, PTSD, not working, lives with mother and younger brother, some legal issues. It sounds like family dynamics are quite complicated. The patient is brought in. No information is given to the mother, but the provider listened to the mother. He's angry at the neighbors for causing problems with the police and following me. Perseverates about cameras being inserted around his house to track him. And he references people following him when he's leaving his house. He's scheduled for an on-site visit the next week with nursing for further assessment and the urine screen. And the patient presents the next day, but is impatient and irritable with intake staff. He provides a urine screen, dip positive for bupropion and THC, negative for amphetamines and benzodiazepines. The send out is negative for gabapentin. Confirmation includes cocaine, norbuprenorphine creatinine, 72 nanograms per milligram creatinine, and THC. And apparently the patient is mental health transported. The following day, mother called to leave a message about this, and she's very frustrated. So I'm going to stop here and get some comments from panelists brief on what do you do in this situation with consent and trying to navigate a very, very difficult situation in an unstable patient where you don't have consent to talk to mom or the other prescriber. Dr. Sullivan.
Yeah, these are really, really tough cases. I mean, 42 CFR, I mean, there's like, some exceptions, to be able to, to break that, so to speak, are, one of them would be a medical, emergencies, or welfare of a child or whatnot. So I tend to not speak to anyone's family unless there's a consent, unless a patient's, we can argue their life may be in danger. What's interesting about this case is that the mother is giving us a lot of information about these dangerous prescriptions that he's getting, and he's not allowing us really to talk to her about his care or his other providers. So, I think if you can medically make a case that there may be a severe medical complication of not being able to share or talk about some of this information, you may be able to do it. And there are times where sometimes you do talk to another provider where you do think the medications they're prescribing the person is deadly. We see that with patients who come in who overdose and they die or they get resuscitated. And then we still can't talk to the provider prescribing them. Probably a slippery slope, and maybe my Helio lawyer wouldn't be happy with that. But I do think that if you have a true concern for someone's life and safety, that you are almost obligated, especially with the mother's history of saying she's trying to tell you all this. And if you really don't try to talk to the other physician or something, you might be liable in another way. But certainly no clear answer.
Yeah, it's different. If it's from the emergency department or hospital setting, you don't have the same difficulties with CFR 42, but from the clinic, assuming it's, under, the outpatient treatment, that's sort of challenge. Dr. Bishevitz?
So if you are sending him under mental hygiene transport to an emergency department, he's going to end up in either psychiatry or perhaps medicine, depending on his problems. And then that staff will hopefully be able to make some contact, at least with mother, if not with the treating psychiatrist. That's one way to get around it, on the basis that he's lost some touch with reality. I think you mentioned in the other slide that he was getting very paranoid and thinking people were watching him and so forth. So
Yeah. And so he was not sent from the clinic under MHA, that he actually had that occur at home or while out. So the clinic was made aware of that by the mother. If he was during the intake on the phone, he was tangential, but and recurrent thoughts of neighbors following, monitoring cameras, so interesting, whether or not during the first encounter to try and have someone show up at his house for evaluation or impossible transport or not, maybe a good thing, maybe a challenging thing for establishing rapport. Dr. Moore, we're going to go just a couple minutes over here, but
Yeah.
Looking at the time for restarting the slide. Go ahead.
While there 42 CFR has already been referenced, the federal regs, there are state regs, and some states have confidentiality regs that are even more restrictive than the 42 CFRs. One of those states would be Pennsylvania. So when this caller calls in, I mentioned before, going through these scenarios, doing some role playing with staff is so important, because what this caller needs to be told is, one, we can't confirm or deny that so-and-so is a patient here.
Right.
Two, if we internally know that they are, and this caller has a lot of information, I make sure that whoever is fielding or listening to this caller is not in any way involved with the person they're calling about. So, a supervisor, janitor, whoever can take information, just listen, but do not speak. And we go through scenarios so that can be practiced, because it's very challenging. And then the other thing that we frequently do is use contingency management to, in a way, with some motivational interviewing and those kind of stuff. So for example, if they're refusing to sign a consent for drug court, well, we'd say, your drug court is most likely ordered you to sign a consent. We have to confirm that you've been here. Do you really want to do this and not sign a consent? And you can usually talk through a lot of those scenarios. Same with, so you don't want to sign a consent for your insurance company. Do you're going to have to pay up front for your services. So going right down the line, you don't want to sign a script for your pharmacy. We're not going to be able to send your medications over without a consent for the pharmacy. And then we would do the same thing with the prescriber. We would use the state regulations for OTPs often to make them come in daily until they allow us to collaborate with other treatment providers. So, if they want that carrot of not coming in as frequently, they're going to have to, agree to sign the consent so that we can work and help them. So we would definitely admit them, because we have a lot of tools in place to long-term help them. And the best place, the best home for these patients with substance use disorders is a substance use treatment facility. It's not the hospital. It's not the primary care doctor. It's us.
Yeah, no, assuming the caveats, there's not the medical emergency, obviously. So, Dr. Perner, do you have any other thoughts on this?
Not a lot. One of the things in Minnesota that we've done a couple of different times is, because of these regulations that you guys were talking about, if we can't interact directly with anyone or the provider, sometimes we'll try to intervene indirectly through the pharmacist in regards to whether or not they can dispense, not letting the pharmacist know much, but just that we're concerned about what is getting dispensed, and then that pharmacist can make a decision and also reach out to the provider if they're at all concerned about what's being dispensed and choose whether or not they want to truly dispense it.
Yeah, that's a good comment. Dr. Davis, any final comments?
Yeah, I don't know if this will pass the Helio attorney test, but I've called providers and I understand that they can't talk to me without a consent. And yet in this instance, this provider has prescribed polypharmacy that's ill-advised. And without even mentioning the patient's name, I can refer to the constellation of medicines and honestly relate that there's a concern.
Yeah, so that definitely, you would hope that the ED staff, social workers, psychiatrists reach out to the prescriber, and from that end, and that maybe also be getting consent for the hospital, speaking to the team, talking to them to reach out to the psychiatrist. Sometimes follow through from hospital busy, while it should be done, sometimes isn't. So we're going to move ahead, and what ultimately happened with this patient is the hospital actually contacting the psychiatrist several times. There have been a couple of ED visits and CPAP visits, and ultimately did stop prescribing, but it took quite a long time. And then ultimately there were some complaints filed as well to the state board, because there's some other patients, but it was really challenging and very frustrating to see this going off the track, and a lot of harm ongoing with prescriptions. So it certainly could have spent more time with that, and apologize for going over. I just want to end with a final thought. And this is from one of the top 50 AA speeches of all time. If you go Google top 50 AA speeches, there's it comes invariably to one of the sites, I think a blog from London, but some excellent recordings. And one of the Tom B says, "Abstinence is not sobriety. Sobriety is purity of heart and clarity of mind." And with that, I will
Here.
thank you all. I want to thank the panelists for joining. Alex, correct me if I'm wrong, but we have the next Friday Addiction Talks Case Conference on May 6th.